much again. Appreciate the invite. I will show a case of wide neck bifurcation aneurysm treated with web. It's an on-label treatment. You've already seen several elegant examples of web treatment. For us, over the last 17 years or so, this device has had the most impact on our practice. And MCA bifurcation aneurysm is the most common aneurysm that we treated this year, endovascular. So this is a case of a ruptured anterior communicating artery aneurysm, Hunt-Hess grade 2 in a 58-year-old woman. You can see the large pseudoaneurysm component. And again, I won't go into the measurements because this has already been discussed. But for me, the concept that has helped the most is that all we are trying to do with these measurements is to get the device situated at the neck so that the braid is perpendicular to the inflow, and what is beyond the neck is not relevant, is only relevant in terms of securing the neck. So we're not intending to fill the whole aneurysm with the device. We just want to position it at the neck. In this case, it's a wide neck ACOM aneurysm, incorporates both A2s. There is a contralateral patent A1 segment that also supplies the contralateral A2. Certainly, this aneurysm can be treated with balloon assistant, certainly stent assistant. It's an acutely ruptured aneurysm. And the measurements are given here. The height of the aneurysm that we decided for the web sizing was 6 millimeters. And again, deeper aneurysms are easier to treat with web because there's more depth to manipulate the microcatheter. So this is the access, in this case, a 90 centimeter long sheath, 6 French Sophia, and a VIA 21. The intermediate catheter is just proximal to the siphon. And we position the microcatheter in the, towards the distal half of the aneurysm. As we know, as the device, it's a 7x4 SL, as it comes across the siphon, it will tend to pull the microcatheter back. We really have found that using both hands has been extremely helpful in controlling the device, because not only you have to control the device, but the movement of the microcatheter. It's a fairly dynamic process, not dissimilar to deploying a flow diverter, but requires a little more coordination because we're working in a smaller space. And so here the device is barely out. We're proceeding very slowly. It jumps into the pseudoaneurysm, which is okay. We bring it back. The device is, you can see how dynamic the motion is going back and forth, and that's why it's important to use the right and the left hand together. The device is deployed. One thing I would point out, the catheter is distorting the anatomy a little bit, so when the device detaches, it will settle down inferiorly, and so we have to keep that in mind. Device is deployed, not detached. We do an angiogram, and we can see that it is covering the neck of the aneurysm. We were concerned a little bit at the bottom aspect, but again, as I said, that once the microcatheter comes out, the device will tend to settle down a little bit because of the curvature in the anterior cerebral artery. The pseudoaneurysm component is already not filling. We always do a DynaCT because it has helped us in some cases to reposition the device or to remove and place a different device. This is the reconstruction from the DynaCT. You can see that the anterior cerebral artery and the A2 segments are patent. There is stasis within the aneurysm. We do a control angiogram before detachment. The aneurysm is already occluded. It's a pretty wide neck aneurysm. Some flow seen at the bottom half on the lateral projection, but significant stasis. So the detachment of the device can be tricky, especially if we're in a curved anatomy and the force on the catheter will try to move it up. The microcatheter is advanced back to the detachment marker on the web device. In this case, we had a little bit of a sticky detachment. We did flush the microcatheter, which helped bring the microcatheter back and detach the device. And you can see as the microcatheter comes back, the device will settle down inferiorly towards where we thought there was a little space. The microcatheter is removed. This is the immediate detachment angiogram. After a couple of minutes, this is the final control angiogram. And just to be sure, we also checked the contralateral side to make sure there was no occlusion on the other side. I don't have time to show the second case. I'll just run through it. This is an example of an odd-shaped right MCA bifurcation aneurysm. Again, the sizing is based on making sure that the device sits in the neck of the aneurysm. This is a via 27 because it's an 8 millimeter device. And 50 seconds, so we'll run through it. This case took about 15 minutes from puncture to closure. Normally, a 9 millimeter MCA bifurcation with a wide neck incorporating an M2 will take at least 10 to 12 coils, about an hour. And as Lucas already showed, the device, once deployed up to about 60%, and is pretty safe to manipulate. And this is the post. Again, we leave a little neck remnant that incorporated the M2 branch. So this is occlusion on table, especially when an aneurysm has a relatively narrow neck. The occlusion is instantaneous. I have 8 seconds, so I will stop right now. Thank you.